Good afternoon, doctors and professors. We will now start the session with adjuvant chemotherapy post-curative treatment for hepatocellular carcinoma be a paradigm shift, chaired by Dr. Yang Saks Lim. Dr. Lim, please.
Good afternoon, ladies and gentlemen. Thank you very much for participating to this session, despite very nice weather outside. The title of this session is HCC3, Will Adjuvant Chemotherapy Post-Curative Treatment for HCC be a Paradigm Shift? And I will chair this session, and my co-chair is Professor Junji Furuse, who will participate this session online. Professor Furuse, would you introduce yourself?
Thank you very much. I'm Junji Furuse, and I joined online, but I'm not sure, but camera doesn't work. So thank you very much. Professor Lim, please go ahead.
Yes, so the first and second speaker will be introduced by myself, and the third and fourth speaker will be introduced by my co-chair, Professor Furuse. And the first speaker is Professor Masafumi Ikeda. Professor Ikeda, just a moment, please, is the chief of Department of Hepatobiliary and Pancreatic Oncology at a National Cancer Center, Hospital East. And the title of his talk today is Will Adjuvant Chemotherapy Post-Curative Treatment for HCC be a Paradigm Shift? Professor Ikeda, please.
Thank you very much. Hi, everyone. I'm Masafumi Ikeda, National Cancer Center, Hospital East, Japan. First of all, I would like to thank the President Sina for inviting me to this APASL 2023. Also, I would like to thank the Professor Furuse and Professor Lim for kind introduction. It's my great honor to have an opportunity to make a presentation today. The theme given to me will adjuvant systemic therapy post-curative treatment for HCC be paradigm shift? This is my disclosure. Today's agenda of the perioperative therapy for HCC. First one is adjuvant therapy and neoadjuvant therapy. I will talk about adjuvant therapy first. This slide shows the development of the adjuvant therapy for early HCC. In 2016, adjuvant sorafenib STORM trial was reported. However, the trial result was negative. In 2023, adjuvant atezolizumab IMbrave 050. And in 2024, adjuvant sintilimab and adjuvant radiotherapy IMRT was reported and positive result. Firstly, I will talk about STORM trial. This is a study design of the adjuvant sorafenib versus placebo phase 3 trial. HCC patient after curative resection or ablation were randomly allocated to a sorafenib arm and placebo arm. Tumor condition was single and any size for resection. Single and 5 or less centimeter, 2 or 3 nodule, 3 or less centimeter for ablation, and no vascular invasion. Primary endpoint was recurrence-free survival, intention to treat population. This is a result of the recurrence-free survival and overall survival. As you can see, the both Kaplan-Meier curve was quite identical. Adjuvant sorafenib demonstrated no significant treatment effect with sorafenib with regard to RFS and OS. Next trial is IMBRAVE 050. This is a study design of the phase 3 trial of adjuvant atezolizumab versus active surveillance. The study subject was HCC patient with high-risk recurrence after curative treatment, including surgical resection or ablation. The primary endpoint was recurrence-free survival by independent review facility. This is a high-risk criteria by curative treatment. For surgical resection, 3 or less tumor with largest tumor more than 5 centimeters. 4 or more tumor with largest tumor size is less than 5 centimeters. And vascular invasion or poor tumor differentiation. For ablation, 1 tumor and 2 or 5 centimeters. And multiple tumor and all tumor size was 5 or less centimeter. So in this trial, high-risk criteria for recurrence was set. This is a treatment outcome of RFS and OS. 1 year RFS was 78% in atezolizumab arm and 65% in active surveillance arm. Hazard ratio was 0.72. P-value was 0.012. Adjuvant atezolizumab demonstrated significantly better RFS. However, no significant difference on overall survival was seen between both arms. Although the OS event was occurred in only 7%, so sufficient follow-up is needed in this trial. Next one is adjuvant sintilimab versus active surveillance phase 2 trial. HCC patient with macrovascular invasion after curative resection were randomly allocated to a sintilimab arm and active surveillance arm. Primary endpoint was recurrence-free survival, ITT population. This is a result of the RFS. Median RFS was 27.7 months in sintilimab arm, 15.5 months in active surveillance arm. Hazard ratio was 0.534. P-value was 0.002. So adjuvant sintilimab demonstrated a significantly better RFS. Also, adjuvant sintilimab shows a trend toward better overall survival. Hazard ratio was 0.505. Final one is a RAISE trial, adjuvant radiotherapy, IMRT versus control, randomized phase 2 trial. HCC patient with largest resection margin of less than 1 centimeter after R0 resection were randomly allocated to adjuvant radiotherapy, IMRT arm and control arm. Primary endpoint was recurrence-free survival. This is a result of the RFS and recurrence site. Hazard ratio was 0.55. 2-year recurrence-free survival was 78.74 in radiotherapy and 58.39% in control arm. So post-operative adjuvant IMRT improves RFS benefit for HCC patient with narrowed surgical margin. In terms of the recurrence site, intrahepatic recurrence was well controlled. However, extrahepatic recurrence site was not suppressed. This table shows ongoing clinical trials for early-stage HCC. Nivolumab versus placebo, pembro versus placebo, durvalumab plus bevacizumab versus placebo, Camrelizumab plus riboceranib versus active surveillance. The development of adjuvant immunocheckpoint inhibitor after curative treatment were currently underway. Next topic is the neoadjuvant therapy. This is a design of the phase 2 trial of neoadjuvant semiplimab, anti-PD-1 antibody for resectable HCC. Patients with resectable HCC were enrolled in this trial, and neoadjuvant semiplimab was administered at a dose of 350 mg per body every 3 weeks, 2 cycles. Primary endpoint was pathological responses. Total of the enrolled patients is 21. 20 patients had a surgical successful resection. Right figure shows a pathological response and radiological response. Upper size is a pathological response. Lower size is a radiological response. 4 patients, 20%, and 3 patients, 15%, achieve the major pathological response and partial response, respectively. Next trial is a randomized phase 2 trial of neoadjuvant nivolumab versus nivolumab plus ipilimumab. Patients with resectable HCC were randomly assigned to a neoadjuvant nivolumab every 2 weeks, and neoadjuvant nivolumab plus ipilimumab every 4 weeks and every 6 weeks, 4 doses. Primary endpoint was safety and tolerability, so not efficacy. This is a result of the objective response rate and measure pathological response. Neoadjuvant nivolumab, neoadjuvant nivo-ipi. Among 27 patients were enrolled. 7 patients had a surgical cancellation, but it is not due to adverse event. 6 patients achieved a major pathological response with no recurrences. Based on these 2 neoadjuvant trials, neoadjuvant immunotherapy demonstrated feasibility and some effective signs. These findings support further development of neoadjuvant immunotherapy for resectable HCC. I move to the borderline resectable HCC. This is a concept of the borderline resectable HCC. Borderline resectable HCC had a risk of the post-hepatectomy liver failure, oncological disadvantage, and technically difficulty. So HCC patients with high risk of the recurrence may have little effect on prolonging survival, even after liver resection. This is a resectability classification of HCC proposed by Professor Hatano, Kyoto University. HCC is divided into the resectable, borderline resectable, unresectable disease based on the distant metastasis, macroscopic curative resection, ICG value, and vascular invasion. This is a treatment outcome of the borderline resectable HCC. As you can see, the Kaplan-Meier curve is located in the middle between the resectable disease and unresectable disease. Also, recurrence-free survival was poorer in borderline resectable disease as compared to the resectable disease. So, borderline resectable HCC has a poor prognosis with liver resection. This is an expert consensus of oncological resectability classification of HCC by Japanese borderline resectable HCC expert. Resectable disease, resectable status was defined to a single nodule. Multiple nodule less than 3 or less nodule or 3 or less centimeter. Or vascular invasion of 0 or 1. Borderline resectable 1 was defined to be a 3 or 5 nodule and 3 to 5 centimeter. Vascular invasion of 2 or 3 and localized extrahepatic spread. Borderline resectable 2 was defined to be a more than 5 nodule and more than 5 centimeter. Vascular invasion of 3 or 4, or extrahepatic spread. The definition of the borderline resectable HCC has been established by expert consensus. This is a study concept of multicenter prospective study of conversion surgery by lenvatinib treatment. Tumor condition of inclusion criteria was technically or oncologically unresectable. That means that borderline resectable is included in this trial, in this study. Tumor condition A was intrahepatic vascular invasion. B was synchronous extrahepatic metastasis. C was both A and B. D was a macroscopic residual tumor. E was a metachronous extrahepatic metastasis. Lenvatinib was administered at a full dose for 4 to 8 weeks. After the lenvatinib treatment, resectability was re-evaluated by a CT or MRI. If the tumor response as CR or PR, usual surgical resection will be planned. If the tumor response as SD, if technically possible, surgical resection was conducted. This is a patient characteristics and patient flow. In patient characteristics, tumor condition was majority, 65% in tumor condition A. Total of the 49 patients were enrolled in this study. The resection rate was 67.4%, so quite high resection rate, and primary endpoint was met. This is other treatment efficacy. Overall survival, progression-free survival, objective response rate, and overall survival by resection status. OS, PFS, and OS in resected patients were very favorable result. So at present, we are conducting the neoadjuvant leopard regimen followed by resection for borderline resectable HCC. This is our phase 2 trial. Leopard regimen consisted of the full dose of the lenvatinib for 4 weeks and hepatic arterial infusion chemotherapy with cisplatin at a dose of the 65 mg per square on day 1. After 1 cycle of the leopard regimen, resectability was re-evaluated. If possible, we move to the surgical resection. In this trial, the definition of the borderline resectable was vascular invasion, VP, VV, or B. The primary endpoint was resection rate. This is an ongoing clinical trial. Why do we select the leopard regimen? This is a multicenter phase 2 trial of lenvatinib plus hike with cisplatin for advanced HCC. Advanced HCC patients with no prior systemic therapy were enrolled in this leopard trial, and we administered the lenvatinib plus hike with cisplatin. The primary endpoint was objective response rate by modified RECIST central assessment. This is a result of the objective response rate. Objective response rate was 64.7% by modified RECIST central assessment and 45.7% by RECIST 1.1. So lenvatinib plus hike with cisplatin had a promising objective response rate. This is a partial response cases. 70x years old male, alcoholic liver disease and multiple HCC. After the administration of the leopard, tumor marker was rapidly decreasing. This is a CT scan. Before treatment, 6 months later. Before treatment, 6 months later. As you can see, remarkable tumor shrinkage effect was seen in this patient. This table shows a comparison of the treatment outcome between leopard and first-line standard systemic therapy. Sorafenib, lenvatinib, atezolizumab, durvalumab, and leopard regimen. Even though the leopard regimen is a phase 2 trial, however, the objective response rate is best in leopard. And overall survival was very similar to the atezolizumab plus bevacizumab. So, and also cost is very less expensive. So leopard is an IO and beva-free regimen, so easy to manage in the peri-operative setting and less expensive. So my title is Will Adjuvant Systemic Therapy Post-Curative Treatment for HCC be a paradigm shift? My answer is maybe. In my take-home message, various peri-operative treatment, particularly immunocheckpoint inhibitor, are being developed for resectable and borderline resectable HCC. At the present, no standard treatment has been established yet, but near future, standard neoadjuvant therapy will be established for resectable HCC. Thank you for your kind attention.
Thank you very much, Professor Ikeda, for a very nice lecture and for keeping the time. And we will have the discussion at the end of this session, but we will have just one quick, urgent question to Professor Ikeda. Do you have any question? No? Yes, we will discuss later.
Okay.
Thank you very much, Professor Ikeda. And next speaker will be Professor Thomas Yao from University of Hong Kong. He is a well-known oncologist, and I don't need the detailed introduction for him. And the title of his talk is the same with that of Professor Ikeda. Will adjuvant chemotherapy post-curative treatment for HCC be a paradigm shift? Professor Yao, please.
Okay, so I have to thank the organizing committee for inviting me to actually talking about a very similar topic. Okay, so will adjuvant chemotherapy post-curative treatment for hepatocellular carcinoma be a paradigm shift? So this is my disclosure. So before we talk about the adjuvant treatment, and so we have to look at the time course of patient with hepatocellular carcinoma. So typically, if you see a patient with hepatocellular carcinoma, they may come with early disease. They usually resectable, and then majority of this patient unfortunately don't have adjuvant therapy in few years ago, and then they will run into unresectable HCC. Unresectable HCC, we have like all the TACE, and then we have all the ultrasound guided ablation, and then now some of the patients can have immunotherapy combined with TACE, and then some of almost half of this patient, they go into extra hepatic spread, and then or they have a numerable intrahepatic recurrence, and then this patient subsequently die, okay, of the disease. So one unfortunate thing about hepatocellular carcinoma is that when the patient evolves from the early cancer to the death, the tumor burden is actually higher and higher. Another thing is the patient actually get worse liver function on the line of treatment because of all the systemic therapy, TACE, and surgery. So if you want to treat, give systemic therapy, from our opinion, you are better give systemic therapy when the patient have no tumor burden and they have the best liver functions. So this is just the concept. Okay, so this curve show you that with the time of treatment, liver function of the patient deteriorate dramatically. So we show this paper published by our surgeon, Professor Wondy Poon, is actually a showing the like we have almost 400 patients with a potential curative resection at Queen Mary Hospital. At that time, the 5 years survival is not that good. It's around at best 50%. So what is the factor associated with improved survival after curative resection? First, you have to reduce the perioperative mortality. Second, you have to get a good surgeon and lower the frequency of the margin involvement. Third, you have to reduce the perioperative blood transfusion. A lot of people don't know blood transfusion is actually immunosuppressive. If you get more blood transfusion, you will suppress the patient more, and it is more likely for recurrent. And fourth is the early detection of HCC. So this curve just show you that adjuvant therapy at that time did not play a role in patients with hepatocellular carcinoma. So what kind of, so if you look at all these patients, so what is the pattern of recurrence after the surgery? So around 40% of the patients, they have intrahepatic recurrence. Around 12% of the patients, they develop extrahepatic recurrence, and the other patients, they have both. And then if you look at the late death mostly due to the tumor recurrence, and some of the patients, after operation, they die from the liver failure. We have very few patients die from GI bleeding or sepsis. Remember, why it is important to give adjuvant therapy? Because from our study, tumor recurrence rather than underlying cirrhosis is the main cause of death in this group of the patient. So once again, in our study, what is the risk factor for HCC recurrence? So you have to take into 3 factors. First is the tumor factor. How aggressive is the tumor based on the microscopic feature? If the tumor have a size is greater than 5 centimeter, or the patient have multiple tumor, and also the tumor have a following microscopic feature, like the tumor have microvascular invasion, microsatellite nodule, or polydifferentiator, and the biology of the tumor not favorable, like if the patient have a high AFP, high proliferation index, or a sign of angiogenesis. And then host factor first depends on the general health of the patient, hepatitis activity, and whether the patient have a severe cirrhosis or not. And thirdly, it depends on the surgical factor. As why I say, the resection margin of the patient, and also the perioperative blood transfusions. So if you're talking about the recurrent, usually we will just lump together. For HCC, you have to classify it, whether it is a early recurrent or late recurrent. So remember, intrahepatic recurrent, we usually classify into early or late. Risk factor for early recurrent, like tumor rupture and venous invasion. Risk factor for the late recurrent is the patient with cirrhosis. So by comparisons, majority of the patient early recurrent, they have a intrahepatic metastasis. 100% of the late recurrent, they are multicentric occurrence. So prognosis of the early recurrent actually worse than the recurrent of the patient. If you look at the median survival, for the early recurrent is around 16 months versus 30 months for the late recurrent. So that's why we have to have a rational use of the adjuvant therapy. So that's why I say the rationale is HCC patient frequently experience recurrent, and then current aggressive treatment of recurrent is majority of the time, if you work in a surgical predominant center, it's just resection, ablation, TACE, and then prevention of recurrent undoubtedly can improve the overall survival of the patient. You can improve, you can, so two potential roles of adjuvant therapy, it can decrease the early recurrent, mainly the intrahepatic metastasis, and also hopefully it can reduce the de novo hepatocarcinogenesis. So that's why I say, remember there is a bimodal recurrence after HCC resection. The first, peak of recurrence is actually occur between the peak around first year. It is due to, it's most likely the intrahepatic recurrence, and then the late recurrence, as I say, is more related to the de novo hepatocarcinogenesis due to the cirrhosis, so it occurs around 4 to 5 years after resections. And then another very important thing is that a lot of people don't think you should give antiviral to a patient after surgical removal. So this is one of the papers we published more than 12 years ago. It shows that if the patient have a high HBV DNA level, it actually increase the risk of recurrence after resection of the HBV HCC. So we analyzed around 72 patients treated at Queen Mary Hospital, and then we find that if the patient who actually have a high viral load as such, this patient have a higher risk of recurrence than the patient with a no viral load. So I think one of the main reasons is that the antiviral load may be effective in reducing the novel hepatocarcinogenesis. And then if you look at further analysis, here we've got another paper, 136 patients received hepatectomy for HCC related recurrence. So we compare 42 patients received antiviral, another 42 patients did not. Antiviral using the nucleoside analog. So if you look at the overall survival here, it's key, make a very clear difference. And then altogether, apart from our study, other centers also have done very nicely other study. So people have published the meta-analysis about the antiviral therapy after resection or RFA of the HBV-related HCC. So altogether, the meta-analysis, they lump together 5 cohort study. They have together around 200 patients on antiviral, 300 patients didn't on antiviral. The meta-analysis did confirm if you put a post-surgical patient on antiviral, the nucleoside analog can significantly reduce recurrence by 41%, reduce the mortality from liver failure for around 85%, and overall mortality is 73%. This is important finding. So if you talk about randomized study of all the adjuvant therapy HCC, what is interesting is this paper actually published in Annals of Surgery. I think it's by the Taiwan group. They actually randomized a 200 patient who actually have a R0 resection for HBV related HCC. And then they give the adjuvant antiviral adenofar versus no treatment. You can see the treatment group, the patient who actually received the antiviral have a better survival than the patient didn't receive the antiviral. So For adjuvant treatment for hepatocellular carcinoma, what is important, you have to balance the benefit from the adjuvant therapy, and also you have to think about the which group of the patient have a higher risk of recurrence. So what kind of patient have a higher risk of recurrence? So you have to refer to our Hong Kong liver cancer staging system. It based on all these factors. The resection risk depends on the tumor size. 5 centimeters of patient, they have a higher risk of recurrence, regardless of the whether the patient have a MVI and tumor differentiation. So if the tumor have a multiplicity, they also have a higher risk of recurrence. Clinically, the size, whether the patient have microvascular invasion and also poorly differentiation, is also have higher risk of recurrence. For the patient who actually have abrasion, the risk of higher risk of recurrence obviously is the tumor size. So usually people don't perform radio frequency ablation for tumor size greater than 5 centimeters, and also the multiplicities. So for the adjuvant therapy post-operation, what is important? Okay, what is important is you have to identify the appropriate group of the patient. Like this group of the patient, they actually have a higher risk of recurrence. If I say, as a medical oncologist, not everyone after post-surgery need adjuvant therapy, but you have to tailor-make to a group of the patient you think they have a higher risk of recurrence. As say, so people have done a lot of adjuvant therapy, published like using the chemo prevention, using the polypolonic acid, published in New England, more than 30 years ago. Transarterial iodine, published in Lancet, adoptive immunotherapy interview. However, they are only support mostly by a single center trial. It cannot be reproduced anywhere outside that center. And then what is quite commonly practiced in, especially in Asia and China, is people will try to do adjuvant TACE after resection. So this is one of the meta-analysis showing that adjuvant TACE, actually for the overall survival and recurrence, actually favor the use of the adjuvant TACE. However, I say this is a meta-analysis. So then, as the previous speaker Akita have talking about the hepatic arterial infusion chemotherapy. So this is another meta-analysis of all the hepatic arterial infusional therapy. Actually, we see a trend of the post-op adjuvant hepatic arterial chemotherapy, but as what I say, majority of the follow-up, they are quite brief, and they are single center, and the quality of the surgery and also the HAI may not be good. So I think we're still not there yet. And then a lot of people 10 years ago have a lot of hope about using targeted therapy, especially sorafenib after adjuvant. You can see in this STORM study, basically from day 1 to long-term follow-up, the use of the targeted therapy is actually cannot improve survival at all compared to the placebo. So I think Akita have talking very nicely about the I'm Brave study. So I just spend few slides to echo that study. So all these adjuvant HCC study actually originated from the MBRAVE 150. So I think all of you know the MBRAVE 150, which actually get the standard for advanced HCC. And then they put the regimen from the metastatic stage to the adjuvant stage. And then if you look at both arms of patient, one arm of the patient receive the atezobev, another arm of the patient receive active surveillance, and then the primary endpoint is recurrence-free survival. And then they get published in Lancet last year. And then, as what I say, it is a adjuvant study. They actually get the patient with resectable hepatocellular carcinoma. Majority of the patient have a childhood class A cirrhosis. Notably, we have all the patients have a high risk of recurrence, as what I said before. And then half of the patient receive Etisobev, and other half of the patient receive active surveillance, and then study endpoint recurrence-free survival. This is the statistics. So this is the demographic factor, so you may not see it well. So it is quite well balanced between the two groups. They have like 330 patients in each group. Majority of the patients, they are early stage disease, and then majority of the patients, they recruit from the Asia Pacific area. They have underlying hepatitis B infections. And then if you look at the primary endpoint, IRF, you can see the two curves separated after 3 months and then remain separated. And then after like 18 months of follow-up, surprisingly, the two curves come together. So I hope to see a longer-term follow-up of the I'm brave to see the true benefit. And then majority of the subgroup, they have a trend to favor the use of the Etisobev. And then safety. So how a lot of surgeons ask me how safe is to use Etisobev after the surgery. Surprisingly, this study show using Etisobev post-op is very safe. So serious adverse event is actually quite few. The severe event treatment-related is only occur 16%. Treatment-related death is only in 6 of the patient. Majority, I have to say, majority of the treatment-related adverse event, they are hypertensions. So overall, so I have to say, so what we have is just the overall survival here. We haven't got, what we have is just the recurrence-free survival here. We still have a lot of question about the OS. So at the time of presentation, because they stopped at interim analysis, OS was highly immature. So they only have around 7% of the event-free survival. So I think we need a more, another 2 years of follow-up to see the true benefit of this adjuvant. Also, very importantly, so you only know the IBRAVE result. What is important is the CheckMate 9DX, Kilo 937, Emerald 2. I think these 3 trials, although they are adjuvant, they are quite different in some extent. So Emerald 2, they have 3 arms. They have the Dura arm and also the Dura Bev arm. The PAMBO study, interestingly, apart from the high risk, they have a group of the patient who actually have intermediate risk. CheckMate 9DX, hopefully you will see the result at the end of this year, and then we will know about the true benefits. So in conclusion, ladies and gentlemen, surgery nowadays still remain a standard of care for early resectable HCC. However, a lot of patients experience high risk of recurrent post-surgery. Adjuvant therapy certainly play a role to reduce HCC in the high-risk population. There is currently no widely accepted definition of HCC. So we have the positive IBRAVE study that you may use the Etisobev in post-op patient if it is approved in your country or center. There are more upcoming immunotherapy or immunotherapy combination data in adjuvant setting. So we don't know, actually, in 2 years' time, whether single agent immunotherapy is enough for all these HCC patients, or we still have to use combinations. Because in all this, what we call adjuvant setting, there is no residual tumor. So what you are tackling is only the circulating tumor. It's very different from advanced setting. you have a residual tumor with tumor microenvironment, the use of anti-angiogenic can increase the infiltration of the T cell into the tumor environment. So I think the verdict is still not there. Thank you.
Thank you very much, Professor Yao. Please note again that we will have the discussion at the end of this session. Thank you, Professor Yao. Next speaker will be introduced by my co-chair, Professor Fruse.
Okay, thank you, Professor Lim. I will introduce it as two speakers. So I'm very happy to introduce the next speaker, Dr. Kaoru Tsuchiya, Musashino Red Cross Hospital. Her title is The Next Step Toward Adjuvant Therapy in Patients with Hepatocellular Carcinoma. Please start your lecture, Dr. Tsuchiya.
Thank you. Thank you for your kind introduction. Good afternoon, everyone. It's a great honor for me to give a presentation at a wonderful conference. And to be honest, I have a lot of stress because the Professor Ikeda already talked about all studies about adjuvant therapy, and there are so famous professors, and we cannot perform advanced therapy in real world practice. So I don't know my mission, but so I do my best. So my agenda is number one is the purpose of the adjuvant therapy in patients with HCC, and number two is we have to think about best candidates of adjuvant therapy in patients with HCC. Finally, we have to think about the regimen of the adjuvant therapy in patients with HCC. So HCC is a special cancer because we always have to consider liver function as same as tumor status. You can see the BCS staging system in all on stage. The liver, the description of about liver function was existed, and in the JSH, Japanese Society of Hepatology guideline, and the number one factor is the liver function. So liver cancer or HCC is a special cancer. When we look the other cancers, for example, you can see the clinical practice guidelines for pancreas cancer from Japanese Pancreas Society. There is no pancreas function or something. There's only the tumor stage. They only think about the tumor status or adjuvant therapy performed according to the tumor status. And you can see the guidelines about lung cancer. So about lung cancer, so advanced therapy performed according to the driver genes or genetic profile, and in liver cancer there is no information about genetic information. So adjuvant therapy in patients with HCC should be, of course, decrease HCC recurrence, and most important factor is maintain liver function and prolong overall survival. So I think we think HCC is a special cancer because we have to consider liver function. So we have to avoid such a situation. No, it's recurrence, it's okay, it's perfect, but and the patient is alive. But if the patient liver function is impaired, so patient have to live with complication of liver cirrhosis, for example, ascites or the varices bleeding. So we have to think about, always think about liver function in adjuvant therapy. So let's think about candidates of adjuvant therapy in patients with HCC. So in IMBLEB 050 study design, they defined the high risk of recurrence. The recurrence is the tumor size or tumor numbers in liver resection or liver ablation. And primary endpoint was successful in the atezolizumab plus bevacizumab group compared to the control group. However, we don't know who has a high risk of recurrence or which recurrence has impact on survival, because only the small recurrence in the liver, we can perform ablation or the radiation or resection. But if the patient had extrahepatic metastasis, we have to start systemic therapy. So we already reported the risk factors for exceeding the Milan criteria after successful ablation in patient with early stage. Early stage means the tumor number within 3 and tumor size is within 3 centimeters. So we performed the radionuclic ablation in 323 patients and complete locally curative therapy, and the patient with high AFP. High AFP means the 1/100 nanogram per liter, and early recurrence. Early recurrence means within recurrence within 1 year. The patient with both two factors, high AFP and early recurrence, easily exceeding the Milan criteria. So we think the tumor markers, especially AFP and clinical factors, early recurrence are very important in thinking when we think about advanced therapy. And next, we try to investigate the conventional tests in early or intermediate stage. We performed the CTs on only 145 people, patients, and the patient mean age was 77, and the tumor number is 1 to 10. And you can see the overall survival. Overall survival it was excellent because the patient are early or intermediate stage. And median overall survival was 4.6 years. However, we investigated the time to progression to BCS stage B. It means we have to perform the systemic therapy in such patient. The 3 years rate of the time to progression of BCS stage C was 21% in early or intermediate stage HCC. And we analyzed separately according to the liver function, because liver function is the most important factor associated with OS in HCC patient. So patient with good liver function, that means modified score 1 or 2A patient, the patient number was 80, and in such patient, the 5-year survival was 82%. However, in such a good liver function patient, the time to progression to BCS stage, the 3 years rate of the time to progression was 22%. So we think under such a patient, the progress to the BCS stage need adjuvant therapy after the CTAs or ablation. And we analyzed the factors associated to OS in good liver function patients. So a high AFP and tumor number are associated with OS. And we also analyzed the factors associated with the time to progression of BCSC in good liver function patients. So the tumor number was only associated with the time to progression to BCS stage C. And interestingly, we performed the same analysis in the impaired liver function patient. So the patient without good liver function, the patient with impaired liver function, no significant factor, only the tumor size was associated with overall survival and time to progression to BCS stage C. So we think a high-risk patient in ablation or conventional TIS is high AFP and multiple tumor number and early recurrence from the recent curative local regional therapy. And the important thing is the risk factors should be discussed based on the liver function, because liver function is the most important factor in HCC treatment. And some doctors dislike the clinical practice because we don't expect the clinical courses before the treatment. However, you can see it's a risk factors in the renal cell carcinoma. So in the renal cell carcinoma, so time from the initial diagnosis to initiation to systemic therapy is the one of the risk factors associated with the prognosis. So in the future, we have to take the clinical courses or a clinical factor in the expectation of the prognosis. And in the last, I will talk about the kind of adjuvant therapy in patients with HCC. So which regimen can we select as adjuvant therapy? So this slide shows the phase 3 trial of the adjuvant therapy for patients with HCC. As the Professor Ikeda or other professors said that IMBRAVE 050 was successful, and other various the studies, including interferon alpha or vitamin K2, were not successful. So, and how about immune checkpoints and monotherapy? We already know the ICI monotherapy shows clinical benefit in around 15% of the patients with advanced HCC in phase 2 and 3 trials. And ICI monotherapy plus TACE did not show clinical benefit on EMERALD-1 study. So we think we need the personal the opinion. So ICI monotherapy not so useful as an adjuvant therapy in HCC patient. So, and we also think about the tumor microenvironment. And tumor microenvironment is different from according to the therapy. For example, there are very surgical stress and surgical progression on tumor microenvironment is different from ablation and embolization. And already reported the postoperative plasmatic dendritic cells select interferon alpha to promote recruitment of the MDSC and drive HCC recurrence. So in such patient, ICI monotherapy is will not so effective in patient after resection or the decrease of MDSC. So you can see in the future adjuvant therapy. Number one is adjuvant immune checkpoint therapies, but monotherapy is not so effective, we think. And number two is neoadjuvant immune checkpoint inhibitors plus adjuvant checkpoint inhibitors. And number three is the neoadjuvant immune checkpoint inhibitors plus adjuvant plus vaccination, or a combination of immune checkpoint inhibitors and VEGF inhibitors are also effective for adjuvant therapy. So in conclusions, adjuvant therapy for HCC should be, number one is decrease the HCC recurrence, and also the important thing, not in other cancers, it's not so important, but in HCC patient, maintain liver function is the most important thing. And of course, prolonged OS is necessary for adjuvant therapy. And we have to investigate the best candidates. The point of the clinical view, the high FP and high recurrence are important factors for the selecting candidates, and best regimen in each patient according to the patient profile and clinical course. Thank you for your attention.
Thank you very much, Dr. Tsuchiya. Very nice lecture. So we don't have enough time to, so we are moving to the last speaker. Okay.
Thank you.
Thank you very much. So I'm very honored. Steve there.
Yes. Okay. So
Okay. So online.
yes.
Okay.
No,
Thank you.
physical.
Thank you very much, Professor Steve Chan from the Chinese University of Hong Kong. He is a medical oncologist and one of the most important key opinion leaders in hepatobiliary and pancreatic cancer field. So his title is Adjuvant Chemotherapy for HCC. Please start your lecture, Steve.
Thank you, Chairman. Also, I would like to thank the APASO for inviting me to speak on this topic. These are my disclosures. Dr. Sumiya has mentioned she has been very stressful because most of the topic have been covered. I think I'm the one who should be the most stressed because all the topic has been covered. So good news for our chairman is I try to make my talk very simple, 15 minutes talk. And also I try to give you a very brief background about the adjuvant therapy. Instead of going through the details of I'm Brave study, I try to give you a deep dive into the data of this study. And finally, I will talk briefly about the future, especially what to do after the failure of the adjuvant immunotherapy. We know that recurrence of HCC is common after curative treatment. This can be intrahepatic recurrence mostly, but sometimes it can also be extrahepatic spread. Many years of study has told us that if you talk about the early recurrence, depends on how you choose your patient for surgery. 30 to 50% of them will have recurrence, and this is associated with worse liver function, some epidemiological factor like male sex, high alpha-fetoprotein, or some of the surrogate of the more aggressive tumor behavior like tumor size, number, vascular invasion, or poor differentiation. And so we know that another 15% patient can have a so-called delayed second peak of recurrence. And this, instead of due to the adverse tumorous features, is more related to the underlying hepatic function. But we know nowadays, apart from these factors, immune environment, as mentioned by our last speaker, also plays a key role. And now we are moving in the era addressing whether we can give PD-1 or PD-L1 combination. Hopefully, we can change this immune environment to reduce either or both delayed or early recurrence. So this is a table showing you the adjuvant anti-cancer. I'm not listing out the antiviral therapy for HCC that have been shown by different RCTs. You can see mostly is some local regional therapy like RT, RD131, or TACE, or HAIC. Sorafenib have been tested, interferon, and also autologous cytokine-induced killer cells. But we know that most of these modalities, despite some positive results, most of them are not commonly used in our standard practice because of some conflicting or inconsistent data. Perhaps because today we talk about immunotherapy, I will bring you back to the this study, which was published nearly 10 years ago, is talking about the adjuvant immuno. But instead of giving anti-PD-1 or PD-L1, it's talking about autologous infusion, okay, of the cytokine-induced killer cells for HCC. And you can see actually it could improve the recurrence-free survival. And the curves seem not to overlap. But the problem, and also you can see the toxicities, overall is quite well tolerated. But for some unknown reason, it's not being accepted worldwide. I think one of the reasons is because generalizability. It's quite difficult to give autologous infusion for all patients after surgery. And also I think another hidden reason is because people do not know the exact mechanisms of these immune cells. They label it as a killer cells, and we know that it's a mixture of dendritic cells, some T cells, some NK cells, and we know as oncologists or hepatologists, we tend to give something that we know the mechanism more precise. And if you do not know exactly which cells is working, I think this is somehow underlying the resistance for the world to use it widely. And then before I give you a deep dive into the IMbrave data, I would like to draw your attention to these, I would consider one of the biggest study to look at the survival of patients after surgery, nearly 4,000 patients published in JHEP. They somehow, based on number of the predictive factor, they classify patients to low risk, intermediate risk, and high risk. And you can see the 1-year RFS and the 2-year recurrence-free survival is quite distinct between amongst all these three groups. And we'll use this to interpret the IMbrave 050 study later. I will not repeat what have been mentioned already. This is perhaps the most important message and also the most controversial slide amongst the HCC field when they talk about the IMbrave 050 study. First, no doubt there's an improvement of the median recurrence-free survival. In fact, it separated very early from the beginning, just within 3 months of the time of follow-up, the first scanning of the patient. And you can also see the red line, the surveillance arm. If you look at the 1-year RFS rate, it's around 65%, which is quite similar to the ERASO classification, as I mentioned, intermediate risk. And then you can see the 1-year RFS rate, it improves to 78%, which is quite close to the low risk. So now there's no doubt that there's some upgrade of the group treated with atezolizumab adjuvantly, and these show that it could reduce some very early recurrence. But perhaps the most controversial or most debatable part is about the 2-year recurrence-free survival. If you look at the 2-year recurrence-free survival is around 50%. So somehow the experimental arm, they reverse back from the low risk, now back to the intermediate risk according to the previously mentioned ERASO classification. And also remember, if you really have a different behavior after surgery, you should have a curve separating like this. They keep separating. But then we see there's some kind of merging between overlapping between the two curves. So meaning that have we really changed the biology completely by just the adjuvant immunotherapy with atezolizumab? And also, of course, when you look at the details of the patient who died from progressive disease, 17 patients out from the atezolizumab arm, 16 patients out from the active surveillance arm, meaning that actually the death due to the recurrence actually is quite similar. So I'm not saying that the atezolizumab is bad for the patient, but I think this is the reason why people are a bit concerned about this performance of this adjuvant arm at the 2 years after the treatment. And this is why I think regulatory and most HCC people, we prefer wait and see whether the curve will separate again after longer follow-up period of time. And of course, the overall survival, I'm not saying that is the most important, but we still can learn something out from the overall survival curve. And I agree with the authors of this paper saying that it's really too immature to see any overall survival differences. And also, mind you that most patients who treated with Atezo-Bev adjuvantly, they also receive some subsequent local treatment. And we know that this will probably influence the performance overall survival between the control arm and also the experimental arm. And but are we able to see OS difference? If you learn from the Keynote 564, which is renal cell carcinoma, initially they also see similar pattern, overlap of the curve around 2 to 3 years afterwards. And then, but later, they see the separation of the disease-free survival. And then around 30 months of follow-up, then they see the separation of the overall survival curves. So perhaps now, for this Iron Brave study, the follow-up duration is 17.4 months. I think at least we need to wait for another 1 year before we can see the separation of the overall survival curve. As mentioned, is confounded by some crossover and also some of the surgery ablation, which may salvage the performance of the control arm. But certainly, I think this study is still important, although we need to wait for longer follow-up data. But what will be the future? I think this is also one study I think mentioned by Dr. Ikeda, recently published by our China colleagues on use just sintilimab without the bevacizumab in resected high-risk HCC, and that you can see there's a clear separation of RFS and also the overall survival. And this somehow have challenged the view, do we need additional bevacizumab or some anti-VEGF inhibition in the adjuvant setting? But of course, this is a phase 2 study. We need other study to confirm this observation. And this is why, as mentioned by our previous speaker, now all these 3 randomized study on different combination of PD-1 or PD-L1 plus or minus BEV will be important in the next 1 to 2 years of time. First, it can tell us whether monotherapy ICI is going to be the important. If yes, we don't need BEV, or whether we need the additional anti-VEGF as the adjuvant therapy. And also, I think this subgroup analysis in the Iron Brave 050 study is also interesting. We know that in some places, especially in Asia, the surgeons or our oncologists tend to give TACE in those patients after surgery as an adjuvant therapy. And you can see somehow the patient, if they've received prior TACE, they seem not to do that well with the Atezo-Bev. Of course, this is a group analysis. We shouldn't draw too much conclusion from it. But this is a study by our group recently showing that maybe when you give chemo, somehow you can also actually affect the MDSC, which make it more immunosuppressive. But I agree that we need further data to see whether we should give adjuvant TC together with the immunotherapy after the surgery or the ablation. So this is one of my last slides. What to do if the patient had progressive disease after the adjuvant Atezo-Bev? Of course, we don't have a high-level evidence. This is a review just published this month by, I think, US group mainly. They try to propose that if the patient have received 1 year of the adjuvant atezolizumab and bevacizumab, again, if the patient have recurrence, we still go back to the MDT. If it's salvageable by transplant or some liver-directed therapy, we still go for surgery or transplant or some local treatment. But if the patient have a kind of untreatable or some disease burden beyond the local treatment, then they propose 6 months of the observation period. If the patient recurrence within 6 months, perhaps they change, go back to other long Atezo-Bev treatment. But if more than 6 months, they propose to go back to the first-line Atezo-Bev. I would say this is some direction we will move ahead. I'm not sure whether we should stick to 6 months or 1 year, or we have other magical figure. I think we need to have more real-world data, but I think we should focus in the future about the study, what are the duration that we can re-challenge with a similar regimen after the adjuvant use. And I think this concept also applies to the IMMray-1 or some other studies where we use the immuno combination before the advanced setting. How to affect the sequence, this will be a very important topic. So ladies and gentlemen, this is my conclusion. No doubt adjuvant treatment can improve the early RFS, early recurrence as compared to surveillance. But I think we all in the same agreement that long-term data is required before we apply it routinely in our clinic. But I'm sure in the future, the management of early stage HCC will be revolutionized, not only by adjuvant, but also by, as mentioned by Dr. Ikeda, the perioperative and also the neoadjuvant therapy. So thank you very much for your attention.
Thank you very much. Excellent lecture, Steve. So we have another 14 minutes in this session. So we move to a discussion. So Professor Lin.
Yes.
Any
We will
comment?
invite all the four speakers on the podium, as well as the designated discussant, Professor Ken Shirabe.
Professor Shirabe, if possible, could you give us some comments on adjuvant therapy for HCC?
Oh, yeah. Thank you very much. Nice presentation for each speaker. I would like to congratulate. Can you hear me? Oh, the audience, can you hear me?
Yes.
Okay. Thank you very much.
Yeah.
I was so impressed that maybe very important point seems to be the selection of candidates for adjuvant therapy. So I would like to ask to each speaker, first of all, what kind of patient should be selected for the adjuvant therapy? Because from the China, sintilimab is very good data, but they focus on the HCC with MVI, vascular invasion. That seems very reasonable for me. How about do you think about that? I would like to ask to all the audience, all the speakers first.
Firstly, I will speak in Dr. Ikeda. So, I agree to the. So, the good candidate for the adjuvant therapy is maybe I think limited to the high risk patients. So, IMBRAVE 050 is also high risk patient, limited to a high risk patient, and also the sintilimab trial is also only vascular invasion, so high risk patient. STORM trial is become negative, but that STORM trial is no limited to high risk patients. So low risk patient is including the STORM trial. So in adjuvant setting, I think my idea is so limited to the high risk patients, such as so vascular invasion or multiple nodules after the resection. In my idea.
I think one of the problem in doing the adjuvant therapy before in the past 20 years, because people apply the adjuvant therapy to the general population, okay? So that's why we end up with such disappointing result. So I think based on the IMBRAVE data, you will see the benefit in the high-risk patient, as what I've mentioned before, the tumor size, vascular invasion, and whether the patient have a poorly differentiation or not. However, I think one of the study, ongoing study, the KEYNOTE is going to address, they also include the intermediate risk patients, okay? So we need to wait for the result of this study to see whether the adjuvant therapy only benefit the high-risk case, or it can be extended to the intermediate case.
Thank you. I think the number one is the early recurrence is the most important factor, and the next is the good liver function is also a good, very important factors. And yeah, of course, vascular invasion is also important, but liver function is associated with overall survival in every systemic therapies. So liver function is very important.
Maybe I agree what had been mentioned. Maybe I change the topic a bit. Actually, I can imagine in the real world, when we have more and more adjuvant data, actually more surgeons will operate on those super high risk. Because you know the Asian surgeons tend to be more aggressive. Even with a macroscopic vascular invasion, extremely big tumor, sometimes with satellite nodules, they can easily resect left, right. So I think perhaps in the real world is more discussion is can we extrapolate these data to these super high risk patients? I believe so, because when you look at the China data, Sintilimab, if you look at the details, the patients tend to be more high burdened. So I would say maybe apart from defining whether we should give intermediate, we should have more real world data to guide us whether we should give in those super high risk beyond the Iron Brave 050 population. This is also equally important.
Okay, thank you very much. Partly, I agree with you. And maybe the Dr. Chia said that the recurrence pattern is also important, not only timing of the recurrence. You know, high risk of recurrence, but the recurrence pattern is like out of up to 7 or distant metastasis, or so. In maybe we cannot talk about not only the recurrence timing, but also recurrence pattern, because even though the patient with a recurrence, some patients survive because the recurrence pattern is not too bad. So super high risk group seems to be candidate of the adjuvant therapy for me. Thank you very much.
I just have one comment about one of our speakers saying checkpoint inhibitor is not useful in the adjuvant therapy. I think you have to be careful, the data is not there yet. Okay, so using checkpoint inhibitor in advanced stage HCC is very different from in the early stage HCC. There's no tumor microenvironment, not much tumor inhibitions. So we have to wait for the data.
The pattern of recurrence. If you look at all the data, intrahepatic recurrence is still the commonest. I think 80% the patient were intrahepatic recurrence. And I think most data, including our data, is if the patient intrahepatic recurrence, of course, bad news for the patient, but still a reasonable good news for patient because we can do a lot of local regional therapy or repeated surgery. And the outcome still better than those patients who develop distant met after the surgery. If you look at our own data, if the patient, the 20%, if they develop extrahepatic disease after the surgery, the outcome is just like advanced setting. Usually the patient will deteriorate quite quickly, and we can't usually, even with a systemic therapy, it cannot, with very excellent response. So I think probably we're looking at two different populations when you have a distant met versus those patients with intrahepatic disease recurrence. I think the Iron Brave study, maybe in the future, they should look at the pattern of recurrence. I think this will also be very informative to our observation and clinical practices.
Maybe I think that we should avoid the very bad recurrence pattern determining the survival, patient survival. I think I agree with you.
Yes, given that most of the recurrences are intrahepatic and manageable by local therapies, do you still believe that the systemic adjuvant therapy is feasible and beneficial for the patients? This question direct direct to all of the speakers. Another point is that we have very accurate imaging studies that can detect the recurrence at very early stage. Most of the patients undergo the meticulous imaging surveillance after surgical resection or ablation.
Yes, thank you very much. So yeah, very good point. So yeah, maybe so intrahepatic metastasis predominant in recurrence pattern, but so adjuvant therapy is maybe systemic therapy is very feasible for the recurrence. So yeah, very I'm very confused, but so TACE or is a target is nothing. So after the operation, so yeah, systemic therapy is a more good candidate for the adjuvant setting. So another one is so today we presented the radiotherapy, but the radiotherapy IMRT is localized control. Local control is excellent, but other extrahepatic or other regional intrahepatic is not controlled. So all of the region is well controlled, so systemic therapy is the first choice for the adjuvant therapy.
I think we have to be flexible and not exclude other local regional therapy, depends on situations. If the patient, like, let's say, have a singular tumor or a small tumor, surgery, RFA, radiotherapy, they're excellent modality. So I think after the patient, I'm actually a bit not completely agree with the Nature review published recently. After the patient have recurrent, it all actually depends on the pattern of recurrent. What is the tumor load of the patient, and also most importantly, the liver function of the patient at that time. So you can give the patient a systemic therapy, a local regional. So the patient can be candidate for surgery or liver transplantation. So systemic therapy is just one of the options, I say.
Yeah, we are so happy with the successful result with IMBRAVE 050 because adjuvant therapy has the duration of the systemic therapy. When we start the systemic therapy in clinical practice, not adjuvant therapy, we cannot say how long the systemic therapy continues. However, in adjuvant therapy, we can say let's say the systemic therapy in 1 year or some limited duration. So we think the adjuvant therapy in systemic therapy are so nice, and we can go forward to in the adjuvant therapy. So systemic therapy is, I think it's good for adjuvant therapy.
I have to say, HCC is still a very difficult disease. And when we already have seen the data of IMBRAVE, you can improve at least the early RFS. When you have the Sentinel data showing that you can improve the RFS, when you have the autologous cells showing that you can still potentially improve with some cellular infusion, I think it's clear that immunoclearance or immunosurveillance plays a role in preventing recurrence. But the problem I think we have been discussing is how to give, which is the best modality. Do we need BAF? How long do we need the immuno? And also, what type of patient to give? I think these all will remain open. And so I think in the future, I think there's a role for immuno as an adjuvant therapy.
Thank you. Is there any question from the audiences? We have online question. For HCC recurrence in cirrhotics, will TACE prior to chemotherapy or immunotherapy be advisable? I think this question means the adjuvant systemic therapy compared to TACE. adjuvant TCE.
My point. I think it's more exploratory point whether we should combine the TCE with atezolizumab, which have been partly studied in some subpopulation of the Iron-Break 050. My personal view is I try to avoid because first of all, TCE we know is not that effective as an adjuvant therapy. I know some may argue against it, but I tend not to give because, as mentioned, we're talking about some microsatellite disease, small disease. I'm doubtful whether the TC can treat, and not to mention that the TC may change the immune environment that they make the adjuvant immuno not very workable. But these are exploratory. I think before we have further data, we shouldn't combine the TCE and the immuno as an adjuvant therapy. This is my personal opinion.
Thank you. My last question will direct to Professor Ikeda, because you have covered the neoadjuvant therapy for HCC patients. So the neoadjuvant therapy before curative treatment for HCC may delay the surgical resection, etc. So there would be cons and pros. Do you support the use of neoadjuvant therapy in general?
Right. So, however, in HCC, the neoadjuvant therapy is not established yet, but in pancreatic cancer, the other cancers, the neoadjuvant therapy is become standard. So, one of the high-risk patients, so such as a vascular invasion or multiple nodule, so that cases is a high risk of the recurrences. So, these cases I think that the neoadjuvant is better than the adjuvant setting. So all patient is not candidate for the neoadjuvant setting, but some high risk recurrences. So very high risk recurrence is a good candidate for the neoadjuvant therapy. So neoadjuvant therapy is required to the tumor shrinkage effect, mark the tumor shrinkage effect. So we try to repart regimen is a very high overall objective response rate. So we selected a high tumor shrinkage effect repart regimen, neoadjuvant setting.
Thank you very much. My really last question is whether really the atezolizumab adjuvant therapy is being used in your daily practice, or it is being reimbursed in each country, in Japan and Hong Kong?
Reimbursed in Japan.
Not yet reimbursed in Japan.
Almost nothing is reimbursed in Hong Kong, so we use adjuvant therapy in some high-risk patients.
Oh, yeah. Thank you. Is there any question or comments? Do you have any, Professor Fruse and Shirabe, do you have additional comments or question?
Thank you very much. I have no additional comments. Thank you.
Now we will wrap up this session. Thank you very much for your active participation, all the speakers and the discussion. Thank you very much.
Thank you very much, moderators. And thank you very much, doctors. We will start the next session from 3:30 p.m. We will start the next session from 3:30 p.m.
お疲れ様でした。
白渕先生、どうもありがとうございました。失礼し
ちょ
ま
っ
す。
と難しいセッションですよ。
難しい。オンライン難しい。どうも、
難しいですけど
またよろしくお願いします。
内容自体が難しいです。はい、ありがとうございました。
どうも失礼します。